Hi everyone. This is Vivek Kulkarni with USMLE RX, and in this lecture we'll be going through the cardiovascular section of the book. Overall, this tends to be a pretty high-yield section for the exam, so it's really important to learn these concepts well. The section will be very heavy on physiology, and a lot of applications of pathology and pharmacology in this section will be based on a solid understanding of cardiac physiology. It takes most students time and practice to really master these physiology concepts. As we go through, we'll explain some of the harder concepts and use images and audio files to drive things home. On the other hand, some of the information basically needs to be memorized, and we won't do much more than just mention those. Along the way, we'll use questions and mini cases to test understanding, and hopefully by the end, you'll have a better sense for the important topics in the cardiovascular section and how to apply them on your exam. Let's start with anatomy, which in this case is pretty short with only one fact: coronary artery anatomy. You might think that this is a small topic in a big section, but actually this is pretty high yield because of how important it is in understanding heart attacks. We'll talk more about myocardial infarction later in the chapter, but now let's just review the coronary arteries. The coronary arteries originate from the base of the aorta. The two main arteries are the left and right coronaries, and they branch into four important arteries that you should know and that are listed here: the left main coronary artery, the circumflex artery, the left anterior descending artery, and the posterior descending artery. There's a lot more detail to learn here, but let's just go over a few of the biggest points. First, the RCA normally supplies the electrical conduction pathways of the heart, including the SA and AV nodes. Therefore, occlusions of the RCA can lead to fatal arrhythmias very quickly. Another important point is that the LAD supplies most of the left ventricle, so that an occlusion in this artery can cause a devastating loss in cardiac function. In fact, this artery is sometimes known as the widowmaker because an occlusion here so often leads to death. That should be a name that's pretty easy to remember. The last big point about the coronary arteries is that they fill during diastole, which is unlike every other place in the body. An easy way to remember why is that ventricular contraction increases pressure in the arteries, causing them to squeeze shut, so they can only fill when the ventricle is relaxed. A couple of other important points about the coronary arteries. Most people, about 80%, have what's called a right dominant heart, when the RCA supplies the inferior portion of the left ventricle via the posterior descending artery. However, 20% of the time, the posterior descending actually arises from the circumflex artery, and that's known as a left dominant heart. Finally, although this doesn't relate to the coronary arteries, it's important to know that the left atrium is the most posterior part of the heart. This is important because enlargement of the left atrium can cause dysphagia or even hoarseness due to impingement of various nerves listed here. Now let's move on to cardiac physiology. This is the bulk of the cardiovascular section. These concepts can be pretty hard to understand, but they're very important to know, not just for the exam, but also for clinical rotations and beyond. A good understanding of cardiac physio is absolutely necessary, so let's jump right in with cardiac output. Now, there are a lot of equations here, but the most important thing to remember about cardiac output is what it actually is. Cardiac output is a measure of the volume of blood that the heart can pump out in a given amount of time. In essence, cardiac output is a measure of how fast the heart is pumping and how much the heart is pumping. Once you have that down, it's easy to fill in the details. If the heart pumps more blood per beat, called stroke volume, cardiac output will go up. It will also go up if the heart beats faster, meaning a higher heart rate, while still pumping the same amount per beat. So, the simplest way to calculate cardiac output is stroke volume times heart rate. Another way is the Fick principle, based on the fact that oxygen is extracted from tissues at a rate proportional to blood flow. This is a formula you should know how to use, and you should spend some time memorizing it. The next equation relates three important things together: mean arterial pressure, or MAP, cardiac output, and total peripheral resistance, or TPR. If this equation looks familiar, that's because it's really just a basic equation of fluid flow. Pressure equals flow times resistance. The rest of the information in this fact is mostly just specific examples and specific definitions, but let's point out a few things. Pulse pressure is defined as the difference between systolic and diastolic pressures. This is important because a high value, often called a wide pulse pressure, is associated with certain pathologies, the major one being aortic regurgitation. We'll cover the details of aortic regurgitation later in this lecture. Another important thing to remember is that faster heart rate only increases cardiac output to a point. If heart rate is really fast, like with a ventricular tachycardia, there isn't enough time for blood to fill into the ventricles during diastole, so cardiac output actually decreases. This next fact really ties together a lot of important information about cardiac output. The three most important variables to remember are contractility, afterload, and preload. Before we get into the specifics, let's just review what each of these means. Contractility is a measure of how effectively the heart can pump out blood. Preload measures how much blood fills the ventricle before systole, and afterload measures how much resistance there is in the aorta to prevent blood from leaving the heart. These three factors interact to produce cardiac output. One analogy that is helpful to keep these things straight is a seesaw. Imagine a seesaw. When you are dropping one block on the left to try to raise another block on the right. In this example, think about how high the second block will rise as cardiac output. What happens if you make the first block heavier? With a heavier first block, the second block goes higher. This is like preload. The more blood there is coming into the heart, the more cardiac output will be. Now, what if the second block is heavier? Then, the second block doesn't go as high, and this is like afterload. The higher the mean arterial pressure in the aorta, the lower cardiac output will be. And finally, what if the pivot point gets closer to the second block? This will make the force of the falling block stronger, and the second block will go higher. This is like contractility, where more contractility results in higher cardiac output, even with the same preload and afterload. With this model in mind, let's get back to the specifics. Anything that increases contractility will increase cardiac output, whereas anything that decreases contractility will decrease cardiac output, and the specifics are listed here. Ready for a review question? A 35-year-old man comes into the ED in hypovolemic shock after sustaining a severe gunshot wound. How do his preload and contractility compare to normal, and what is the effect on his cardiac output? Let's walk through the answer to this question. Since this patient has lost a lot of blood, his preload will be low because there is less blood returning to the heart. In order to compensate, the heart will try to pump more efficiently, so his contractility will be increased. Since these two move in opposite directions, they will have opposite effects on cardiac output. But the overwhelming factor is that the patient is in shock, which means his cardiac output must be lower than normal. In this case, the lower preload is more important than the higher contractility.